You're listening to This Week in Cardiology from theheart.org, Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.
You can now access the latest in medical news on your Amazon Alexa-enabled device. Join me, Perry Wilson, every weekday morning for Medscape Medical Minute, where I highlight the top medical stories of the day. To add Medscape Medical Minute to your flash briefing, search for Medscape Medical Minute on Amazon and click Enable. Or open the Amazon Alexa app, go to Skills, search for Medscape Medical Minute, and click Enable. Then say, Alexa, what's the news? Or, Alexa, what's my flash briefing? I hope you'll join us.
Hi, everyone. This is John Mandrola from theheart.org, Medscape Cardiology, and this is This Week in Cardiology for March 25th, 2022. This week, AFib ablation versus rate control in heart failure, TAVI versus SAVR, atherosclerosis in general, and surrogate endpoints in observational studies. I want to start by making a few very brief comments about my venture in Denmark last weekend. I went to speak to one of the younger research programs in Denmark, Zealand University in Roskilde. This is about 20 miles west of Copenhagen. My topic was communication of science and the use of social media. I went to teach, but my gosh, I am 100% certain I learned more than I taught. Here are 4 of the many things I learned. To be a cardiologist at Denmark, you must complete a PhD. Now, this explains the tremendous amount of research from this small country. And imagine a world where all cardiologists spent years doing research. We'd be almost immune to being bamboozled by spin. For instance, I didn't see any Watchman procedures in Denmark. Second point, Danes trust their government. Pause on that for a second. Third, Danes really do focus on family and value things like paying trainees a good wage and getting home for family dinner and providing extremely generous maternity leave. Finally, all Danes get free health care. And listen to this. To prevent delays, there is a law that if a GP refers a patient to a specialist, that specialist has 30 days to see the patient. And if the specialist recommends a procedure, they have 30 days to do the procedure. If not, the patient can go to the private hospital and the public has to pay. It's brilliant. So thanks again to Drs. Anne Christine Hood Ruval and Dr. Niels Eske Broen for inviting me and for giving me such incredible hospitality. Thanks also to the accomplished researcher Soren Didriksen for the bike tour of Copenhagen, and Uffe Gang and Camilla Asberg for letting me spend the day in a Danish EP lab. Okay, first up, Raft AF. Circulation has published an important trial in AFib called Raft AF. Well, this trial was presented last year during the ACC. Canadian investigators studied the use of primary AFib ablation versus rate control in patients with AFib and heart failure. This is a massively important question because there are so many patients with AFib and heart failure. Now, this was a basic, pragmatic trial, but its interpretation is going to be hard. 2 brief background points first. 1, it is often hard to know the sequence in patients with heart failure and AFib. Did the AFib cause the heart failure? And if this is the case, eliminating the AFib with ablation is clearly helpful. However, AFib may be a bystander, and if so, fixing the AFib may do little to help. Second background point, the Castle AF trial led by my friend Dr. Nasir Marouche compared primary AF ablation to antiarrhythmic drugs in patients with heart failure and found a dramatic benefit for ablation. But, importantly, the Kaplan-Meier curves took time to separate, which suggests that if the effects of ablation are real, they accrue over years. Now, the 2 issues with using Castle AFib as a prior here are that A, there were some internal validity issues with Castle. There was high loss to follow-up, and there were low event rates. So those 2 things create some uncertainty in its findings. The second issue with Castle AF is that it compared ablation to antiarrhythmic drugs, whereas Raft compared ablation to rate control. So the trials had different comparators. All right, now to the Raft study. 21 centers, most of which were in Canada. Patients had to have a lot of AFib and class 2 to 3 heart failure and an increased BNP. And they were randomized to either ablation-based rhythm control or rate control. The primary outcome is a good one, composite of all-cause death and all heart failure events with a minimum of 2 years. They had a bunch of secondary endpoints, including quality of life measures and 6-minute walk test and ejection fraction. The trial began way back in 2011 and it ran to 2018. The planned enrollment was for 600 patients, but the investigators were only able to enroll 411 patients total. And sadly, in 2017, 6 years after the trial started, the Data Monitoring Committee recommended enrollment be terminated and follow-up continued for a minimum of 2 years of all patients. That decision was based on lower than expected enrollment and perceived futility. They made a decision based on data from 363 patients. Now, statistics professor Andrew Althouse has a very, very nice thread on Twitter on the details of this, and I will link to it, and it's worth looking at. It's very educational. Basically, the Data Monitoring Committee calculated that the trial had only a 19% probability of concluding benefit if it finished. Now, more on that in a minute. In sum, there were about 200 patients in each arm. Their mean age was 67, and half were female patients. Important components of the rate control arm were that about a third of the rate control arm had AV node ablation and CRT devices, so they had perfect rate control. Heart rate control was targeted for less than 80 beats per minute at rest and less than 110 for a 6-minute walk test, which is aggressive, and I'll get to that later in the interpretation. So here are the results. The primary outcome occurred in 23.4% of patients in the ablation arm versus 32.5% of patients in the rate control arm. The hazard ratio was 0.71, but the confidence intervals range from 0.49 to 1.03, the p-value 0.067. In other words, the 29% reduction in the primary outcome did not reach statistical significance. The confidence intervals that include 1 include the possibility of no effect. 34 patients died in the rate control arm versus 29 in the ablation arm. That difference of 5 deaths. Sadly, the authors do not tell us the cause of these deaths. A table listing the causes of death would have been extremely helpful to see if these were just other kinds of non-cardiovascular death. 48 patients had a heart failure event in a rate control arm versus 38 in the ablation arm, so the delta was only 10 heart failure events over the course of 7 years. And remember, this was not a blinded trial. The authors also measure quality of life outcomes like change in 6-minute walk test and questionnaires, which all favored ablation. But again, I seriously discount all of these because of the lack of sham control. Now, the adverse events are important. In the table of adverse events, the authors list tons and tons of bad things, some of which are completely unrelated to the treatments, including AFib, which was an entry criteria for the study, and heart failure and death, which were efficacy outcomes and already counted. They also added in non-cardiovascular events, which are unlikely to be affected by either treatment arm. That sort of practice bothers me because it obscures the adverse events you're really looking for. What do you think the AFib ablation adverse events rates were? What do you quote patients for a risk for AFib ablation? Well, in Raft AF, there was a 10.8, 11% major complication rate of AF ablation. This included 8 major bleeds, 1 iliac dissection, 9 perforations or esophageal injuries, and 1 death. Now, to me, this is an important finding. It also speaks to the downsides of AFib ablation because if complications are this high in specialized centers in Canada during a trial, you can be sure that they are that high in low-volume centers across the U.S. and Europe. So the author's conclusions varied a little bit depending on the place in the paper. In the abstract section, they wrote, in patients with high burden AF and HF, there was no statistical differences in all-cause mortality or heart failure events with ablation versus rate control. However, there was a non-significant trend for improved outcomes with ablation-based rhythm control over rate control. Okay, in the discussion section, which far fewer folks read, they wrote more succinctly. They wrote, quote, "In this trial of patients with AF and HF, ablation-based rhythm control did not significantly affect the primary composite outcome as compared to rate control." They then appropriately go on to offer possible reasons that the statistical significance was not achieved. And of course, first is that the ablation is in fact not better than rate control. But another explanation is that it was a type 2 error, false negative, or ablation was better, but due to the early termination and not enough patients, there was not enough power to sort out the signal from the noise. Now, in support of the real signal being there is the fact that ablation of AF probably does take time to show its benefits in heart failure, as seen in Castle AF. But I don't know. Here are my 6 take-home points on Raft AF. First is on the trial stoppage for futility. I urge you to go to table S11 in the supplement. This shows that after 363 of 411 patients had been enrolled in 2017, after 6 years, there were more events in the ablation arm. The hazard ratio was 1.32, 32% worse for ablation. So the data monitoring committee saw a 32% higher rate of events in the ablation arm and concluded that futility. Now, they made some calculations that, of course, I don't understand, but just look at the big picture. With the majority of patients enrolled, you have a 32% higher rate of events in the ablation arm. It seems very unlikely that they were going to be able to show benefit. Now, the corollary to that observation is that in 1 year later, and only 40 more patients, they went from a 32% harm in the ablation arm to a final result of 29% benefit in the ablation arm in just 12 months. That's a lot of positive results at the end of the trial, and maybe it is all due to the fact that it takes time to accrue benefit. Maybe it is just noise from an underpowered trial, but that swing is quite striking. Okay, second point, another reason why I think this is a null trial. As this podcast has discussed previously, heart failure hospitalization is a clinician-dependent decision. The trial is performed at ablation centers. These centers are populated with ablation proponents. So clinicians know the treatment assignment. There may be a non-nefarious bias in having different thresholds for admitting patients in the ablation and rate control arms. Since the difference was only 10 heart failure events, that's small, only a couple of decisions could have swayed the data. Third point, the rate control arm called for very aggressive rate control, at least medically. This could have biased against the rate control arm. Remember that in patients with permanent AFib, the RACE 2 trial compared lenient versus strict rate control and found that lower rates of bad outcomes with lenient rate control. It was a bit of a different population, but still, I find it quite hard to get heart failure patients to that low a rate. Fourth point, the adverse events in Raft AF clearly favor the rate control arm. An 11% rate of serious complications with ablation is a crucial finding, and it's obscured in the adverse events table. There were only a handful of adverse events directly related to the rate control arm. Fifth point, there will soon be meta-analysis comparing the AFib ablation heart failure trials. I worry about these, and of course they're going to be positive. But, as I said, Castle AF compared 2 rhythm control strategies, ablation versus drugs. Raft is different. It compared ablation versus rate control. And the ATRAC trial compared ablation versus amiodarone. So these were heterogeneous trials, and just be careful with the interpretation of the surely positive meta-analyses that are likely to come. And my concluding remark on Raft AF is that this study does not change my status as a reluctant conservative AFib ablation doctor. It should not make us more aggressive about AF ablation, and I remain worried that history will prove that our exuberance of AF ablation is mistaken. All right, next topic, comparing transcatheter aortic valve implantation, TAVI, and surgical aortic valve replacement. Now, I knew TAVI procedures have become more common, but I did not know that there have been over 800,000 of these done in 65 countries, and that is a lot. While transcatheter procedures has been an amazing device, SAVR surgery remains a proven procedure for aortic stenosis. The question of the day involves fairly comparing these approaches so as to better inform our patients, and to do that we need clear and agreed upon endpoints for trials. A group called the Valve Academic Research Consortium, VARC, has met in 2021 and come up with numerous endpoints to assess bioprosthetic valve dysfunction. It's the third time this group of experts have met, and the newest document is called VARC-3. Now, VARC-3 has proposed clinical endpoints such as mortality and neurologic events, which are unbiased and everyone agrees are important, no problem. They have also proposed some controversial endpoints, such as hospitalizations and valve-related thrombus and bleeding and MI and new left bundle branch block. Recently, a group of heart surgeons have published a rebuttal to some of these recommendations on endpoints, which they say bias the comparison in favor of TAVI. Journalist Patrice Wendling has a very nice recap of this on the heart.org Medscape Cardiology. Here's my summary. VARC-3 proposes use of rehospitalizations, and the surgeons say, come on, we know SAVR requires more recovery and it's expected to have higher early rates of readmission, and I totally agree with them. I mean, take Partner 3. Partner 3 was TAVI versus SAVR in low-risk patients with AS, while every other previous transcatheter versus surgical AS trial used stroke or death as endpoints. Partner 3 mysteriously adds in rehospitalizations in the primary endpoint, and to the surprise of no one, TAVI looked better in the short run. It makes no sense to use it in the primary endpoint because it's just going to be higher in the surgical group. It's part of the deal. How to define valve thrombosis is another issue. Using the older VARC-2 definition, the Partner 3 low-risk trial showed a thrombus rate on the valve of 2.6% in TAVI versus 0.7% in SAVR, and this is concerning because valve thrombosis increases the risk of future valve dysfunction, which is a big issue when you're using it in lower-risk patients who are expected to live longer. The new VARC-3 definition raises the bar to call a valve thrombosis. Now you have to have clinically significant valve thrombosis, and this will decrease the number of thrombosis endpoints. And the surgeons make a good point. They say that subclinical thrombi are important to measure because studies have shown that they increase the odds of valve deterioration. Now, VARC-3 has rightly recognized the need to include permanent pacing as an important safety endpoint. That is good because higher pacer rates with TAVI is a serious downside, especially when you're using them in lower risk patients. However, they did not include new left bundle branch block as an important endpoint. So I agree with the surgeons on their criticism of this. New left bundle branch blocks are bad because it creates dyssynchrony, increases the risk of heart failure due to a reduced LV function. Final comments. I love TAVI. It's a great procedure and it is iterating and getting better, but there are uncertainties, especially over the long term in lower risk patients. SAVR is a well-established, successful procedure, and if we're going to compare the two therapies for AS, it ought to be fair, and in my opinion, the surgeons make excellent points. Their complete document is open access, it's well written, and it's short. I will link to it on the show notes. Third topic is cerebrovascular disease, similar to coronary disease. And there's little benefit of intervention over medical therapy in this outside of the acute setting. The American Academy of Neurology has published a new guideline on treating stroke due to intracranial vascular disease. This was based on a systematic review and meta-analysis. Symptomatic intracranial atherosclerotic stenosis is defined as a TIA or stroke attributed to a 50 to 99% focal lesion of a major intracranial artery, and the trials of intracranial atherosclerosis included lesions of the middle cerebral, intracranial carotid, basilar, and vertebral arteries. Journalist Sue Hughes has great coverage of this lengthy document, but here is what I was drawn to. Recommendations related to percutaneous transluminal angioplasty and stenting are informed by several randomized trials that showed no benefit of intervention with either a self-expanding or balloon-mounted stents over medical therapy. In fact, the 3 trials have shown higher rates of periprocedural cerebrovascular events and death from intervention and no benefit of stroke prevention during follow-up compared with medical therapy. Instead, the American Academy of Neurology recommends antiplatelet statins and lifestyle modifications to prevent recurrent stroke in patients with high-grade intracranial stenosis. This story makes the podcast because it is A, highly predictable if you consider atherosclerosis a systemic disease. Treatment of focal stenosis does very little to modify the systemic disease. And B, it is quite similar to the coronary situation. Now, I wonder if neurologists will be more successful than cardiologists in ignoring the urge to fix local blockages with intervention. Now, of course, the caveat here is that intracranial stenosis pose a far greater challenge to intervention. These are smaller vessels and there's more tortuosity. But in cardiology, my friends, we have more than 3 RCTs showing no reduction in heart outcomes with focal interventions outside the acute setting, yet the practice continues. Okay, final topic is another rhythm control of AFib topic. The leading cardiology journal, JACC, has published a small, non-randomized, convenient sample study of echo parameters with the conclusion, quote, management of AFib should focus on restoration of sinus rhythm to induce anatomical or functional cardiac cavity reverse remodeling and reduce severity of functional regurgitation. Let me repeat that first part. Management of AFib should focus on restoration of sinus rhythm. Now, let me tell you about the study, and then you will see why this conclusion sitting in a major journal is a problem. French researchers studied 117 patients who were hospitalized for AFib. They did serial 2D and 3D transthoracic echoes at admission at 6 months and 12 months. The 3 groups were defined according to the type of management of AFib and the cardiac rhythm at 12 months. So 47 patients had active restoration of sinus rhythm with ablation or cardioversion. 31 patients spontaneously converted to sinus rhythm, and 39 patients remained in AFib. Now, the authors report extensive amount of data on these 2 and 3D echocardiograms, and the bottom line was this. Restoration of sinus rhythm improved anatomical and functional parameters like lower biatrial and RV volumes and improved LV and diastolic volume. They also found that in the active sinus rhythm group, there was less functional MR and TR. So my comments on this is I want to start positive. This was a detailed paper with tons of echo data, and it's real-world data, and I always commend the collection and reporting of such data. My problems are the conclusions, and here I blame the authors, editors, and peer reviewers. The editorial does a decent job of pointing out some of the many limitations of this study. Small numbers, dropout, multiple comparisons, and the technical dependence of 3D echoes. I would go farther and point out the severe confounding. A clinician decided to pursue rhythm control, right? That decision was based on variables that were likely different among the groups. And in fact, table 1 of the study shows that there's oodles of differences in patient characteristics. And these are just the variables that make the spreadsheet. So it is likely that patients chosen for rhythm control and were able to maintain rhythm control are inherently healthier and would have more favorable echoes. But that isn't all. Echo parameters, especially these highly specific ones, are surrogate endpoints. I never had an AF patient mention their index of atrial volumes. The decision to choose rhythm control in a patient in front of you is one of the most complex decisions we EP doctors make. And everyone agrees that sinus rhythm is better. That is not in question. The question is whether the potential harms of intervention are worth the risk of trying to get to sinus rhythm. Because the path to the treasure of sinus rhythm is like a mountain bike trail. It's often populated with areas of high consequence and potential serious harm. I just don't think echo parameters factor in this decision. It's clinical parameters and clinical outcomes that do. If this paper were in an echo journal and were free of therapy recommendations, I'd have far less objections. But here it sits in JACC with the top-line results urging clinicians to pursue rhythm control, and I see that as a problem. So that's it for this week in cardiology. As always, I am grateful that you listened. Thank you. And remember, if you like this podcast, it really helps if you can give us a rating, write us a brief review on whatever podcast app you use. These things help others find us. Until next week, which is the American College of Cardiology meeting next weekend, this is John Mandrola from the Heart.org Medscape Cardiology.
You're listening to This Week in Cardiology from the Heart.org, Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.